Welcome to the deep dive. Our mission today is, well, pretty straightforward. We're giving you the ultimate shortcut to understanding two major players right there in your neck, the thyroid and the parathyroid glands.
Exactly. This isn't just a quick summary. We're really zeroing in on the critical stuff, the common conditions, how the medications work, and importantly, the nursing interventions that can literally save lives. These glands are endocrine heavyweights.
And when you look at all the information, what really stands out?
Well, it becomes clear we're talking about the body's main metabolic engine room, and also its master calcium regulator. These two systems basically dictate how efficiently everything runs.
So if they get out of whack.
Oh yeah, if they get dysregulated, it immediately impacts patient safety. The whole conversation today really hangs on three core concepts that tie everything together: cellular regulation, nutrition, and gas exchange.
Makes sense. Metabolism and calcium affect pretty much everything.
They really do. If your metabolism speeds up or slows down, or if calcium levels are off, every single system feels it: brain, heart, lungs, you name it.
Okay, before we dive into the conditions themselves, the fast states and the slow states, let's just nail down three key terms. These are sort of our benchmarks for today. First up, the ideal state, euthyroid.
Euthyroid, yeah, it simply means having normal or pretty close to normal thyroid function.
That's the goal, right?
That's always the goal. Whether we're treating an overactive gland or an underactive one, we want to get the patient back to that balanced euthyroid state.
Got it. Next term, goiter. We hear this one a lot.
Right, a goiter is just a visibly enlarged thyroid gland. The key thing here, though, is that a goiter itself doesn't tell you why it's enlarged.
It's just a sign.
Exactly, it's a signpost. It tells you something's up with the thyroid, but not whether it's working too hard or not hard enough. It could be either.
Interesting. So it could be enlarged because it's overproducing hormones.
Correct. Or, paradoxically, it can swell up because it's failing to produce enough hormone. When that happens, the pituitary gland keeps sending signals, telling it to work harder, and that constant stimulation causes the swelling. We'll get into that feedback loop more.
Okay. And the third term, this one's quite specific, exophthalmos.
Yes, exophthalmos. That's the abnormal protrusion or bulging of the eyeballs.
Gives that kind of startled look.
Precisely. It's caused by inflammation and fatty tissue building up behind the eyes. And this is a really important diagnostic clue.
Why is that?
Because the sources are really clear on this. Exophthalmos is present in Graves' disease only. So if you have a patient who's clearly hyperthyroid, maybe they have a goiter but their eyes look normal, you need to think about other causes.
Like that toxic multinodular goiter you mentioned.
Exactly like that. No exophthalmos points away from Graves.
Perfect. So, to recap, euthyroid is normal function, goiter is an enlarged gland, and exophthalmos means bulging eyes, and that's specific to Graves' disease. Okay, I think we're set. Let's navigate the spectrum, starting with the slowdown. Hypothyroidism. All right, hypothyroidism. This is where we see reduced or sometimes completely absent thyroid hormone secretion, and the result? A major decrease in whole body metabolism. It really slows down cellular regulation everywhere. So why does this happen? What are the main culprits, especially, say, in the U.S.?
Well, the most common cause, by far, in places like the United States, is an autoimmune disorder called Hashimoto thyroiditis, or HT.
Autoimmune, meaning the body attacks itself.
Exactly. In Hashimoto's, the immune system mistakenly creates these autoantibodies that target and, well, destroy the thyroid gland tissue.
Wow. So the body's own defenses dismantle the thyroid.
That's pretty much it. It leads to chronic inflammation, eventually fibrosis, scarring, really, and the gland just shrinks and stops working properly. Less hormone gets secreted.
So Hashimoto's is number one. What else can cause hypothyroidism?
There are other causes, too. Sometimes the thyroid is surgically removed, maybe for cancer or large goiter. Radiation therapy, especially to the head or neck, can damage it.
And globally?
Globally, endemic iodine deficiency is still a huge factor. You absolutely need iodine to make thyroid hormones. If you don't get enough in your diet, the gland just can't produce them.
Are there medications that can trigger it?
Yes, definitely. The sources point out a couple specifically. The heart rhythm drug amiodarone can interfere with thyroid function, and so can lithium, which is often used as a mood stabilizer. Both can suppress hormone production.
Okay, let's circle back to the goiter. You mentioned it can happen when the gland isn't working enough. How does that work in primary hypothyroidism like Hashimoto's? It seems counterintuitive.
It does, but think about that feedback loop. Imagine the pituitary gland in the brain is like the thermostat controller. It constantly monitors the level of thyroid hormones, T3 and T4, in the blood. When those levels drop too low, like in Hashimoto's where the gland is failing. The pituitary senses this and thinks, hey, the thyroid isn't working hard enough.
So it tries to boost production.
Exactly. It starts pumping out large amounts of thyroid-stimulating hormone, or TSH. It's basically shouting at the thyroid, make more hormones.
But the thyroid can't respond properly because it's damaged by the autoimmune attack.
Precisely. The TSH binds to the remaining thyroid cells, but they can't really ramp up hormone production. Instead, that constant stimulation just causes the damaged cells to enlarge and swell up.
So that's the goiter. It's the gland swelling under pressure it can't meet.
You got it. It's like yelling at a broken machine doesn't fix the machine, just makes a lot of noise, or in this case, causes swelling. And this explains the classic lab pattern you see in primary hypothyroidism. TSH levels are sky high, but the actual T3 and T4 levels are low.
That makes perfect sense. High TSH, low T3, T4 means the problem's in the thyroid itself. All right, let's talk about what the slowdown actually looks like. If cellular regulation is down, metabolism's down. How does the body show it? What are the cues we need to recognize?
Well, the analogy we often use is that the body's running on a really low battery. Everything just slows down.
Like feeling cold all the time.
That's a big one. Your basal metabolic rate drops, so you can't generate heat effectively.
Yeah.
This leads to significant cold intolerance. Patients feel chilled even when others are comfortable.
And weight gain.
Yep, unexplained weight gain is classic. Even if they're eating less, they gain weight because their body is burning energy so slowly.
What about skin and hair? Does the slowdown affect those too?
Oh, absolutely. The integumentary system, skin, hair, nails, shows it clearly. The skin becomes very dry, coarse, and scaly. It might look pale or even have a slightly yellowish or grayish tint.
And nails.
Nails get thick and brittle, and a very specific sign, sometimes called Queen Anne's sign, is the loss of hair on the outer third of the eyebrows.
Interesting. What about more visible swelling, like edema?
Yes, we see facial puffiness, particularly around the eyes. That's called periorbital edema. But the really characteristic finding is something called myxedema.
Myxedema. Is that different from regular edema?
It is. It's a generalized swelling, but it's non-pitting. If you press on regular edema, it leaves an indent. Myxedema doesn't pit because it's caused by a buildup of these mucinous, sort of gelatinous materials under the skin, not just fluid.
And that contributes to?
It gives the skin a thick, doughy texture. It can also contribute to hoarseness, another common symptom, as those same deposits can affect the vocal cords. Generalized weakness is also very common.
Okay, let's shift to the heart and lungs. You mentioned these are priority areas for assessment where the slowdown gets really dangerous.
Definitely. When the body's demand for oxygen slows down, the heart muscle itself can become kind of flabby and weak. Cardiac output drops significantly.
So what are we looking for specifically?
We look for pronounced bradycardia. That's a heart rate below 60 beats per minute, often quite a bit lower. This leads to poor activity tolerance. They get tired very easily.
Yeah.
And often, paradoxically, you might see diastolic hypertension.
And the impact on gas exchange, how does breathing get affected?
Well, because the body's metabolic needs are so low, the brain's drive to breathe actually decreases. Patients often experience dyspnea or shortness of breath, especially with exertion, and they tend towards chronic hypoventilation.
Meaning they're not breathing deeply or often enough?
Exactly. They're not moving enough air, not getting rid of CO2 effectively. This can lead to respiratory acidosis, and it's actually the #1 cause of death if things progress to myxedema coma. So monitoring respiratory rate and depth is absolutely critical.
Wow. Okay, finally, the brain. This isn't just feeling tired, is it? It affects thinking, too.
Oh, profoundly. It's more than just tiredness. It's neurological sluggishness. Patients report lethargy, overwhelming fatigue, feeling sleepy all the time, somnolence, and having impaired memory and concentration.
Other neurological signs?
Yeah, you'll often see decreased deep tendon reflexes, and they might have slurring of speech. Psychologically, severe depression and apathy, a real lack of interest in anything, are very common.
And you have to be careful not to misdiagnose, especially in older adults.
That's a huge point. In older patients, that confusion, fatigue, memory trouble, it can easily be brushed off as just, getting older. But it could absolutely be hypothyroidism. We need to be really diligent and look at the whole picture, the constellation of symptoms.
Okay, so we've seen the signs. How do we confirm it's hypothyroidism? We touched on the lab pattern earlier. Can you just recap that typical result?
Sure. For primary hypothyroidism, the kind originating in the thyroid gland itself, like Hashimoto's, the pattern is quite clear. You'll see low levels of the actual thyroid hormones, T3 and T4, and simultaneously high levels of TSH.
The pituitary yelling for more production.
Exactly. That high TSH tells you the pituitary is trying, but the thyroid isn't responding. That confirms the problem is primary, within the thyroid. The exception is secondary hypothyroidism, which is much rarer and caused by a pituitary problem itself. In that case, TSH would also be low or maybe near normal, along with the low T3, T4.
Got it. So once it's confirmed, the main treatment is hormone replacement, usually with levothyroxine. Let's really break this drug down, how it works, the absolute must-know teaching points, and key interventions.
Okay, levothyroxine is basically synthetic T4, the main hormone the thyroid makes. When the patient takes it, their body converts some of it into T3, the more active form, inside their cells. This restores normal metabolism.
And it's a long-term thing.
It's lifelong. That's probably the single most critical piece of information for the patient. Stopping the medication means they will go back to being hypothyroid, and they risk serious complications like myxedema coma. They have to understand it's a forever commitment.
Right. Now, the nursing safety priorities around taking levothyroxine seem to revolve heavily around absorption. Why is that so tricky?
It is tricky, and getting it right is crucial for the drug to work properly. There are three main rules we absolutely have to hammer home with patients.
Okay, rule number one.
Consistency and brand. Take the medication exactly as prescribed, same time every single day. And this is important. Do not switch brands from Synthroid to Levoxyl or to a generic or between generics without talking to your provider first.
Why no switching?
Because even small differences in how different brands are formulated can affect how much drug actually gets absorbed. That's bioavailability. A seemingly tiny change in absorption can throw their thyroid levels way off. So consistency is key.
Okay, rule number two.
Timing and food. Levothyroxine needs an empty acidic stomach to be absorbed well. So it absolutely must be taken first thing in the morning on an empty stomach, at least 30 to 60 minutes before eating breakfast.
Just with water?
Just with a full glass of water. No coffee, no juice, no fiber supplements, nothing else. Food, coffee, even some supplements can significantly interfere with absorption in the gut.
Okay, and rule number three, the big interaction rule.
Yes, this is a major safety alert. Several very common things: iron supplements, calcium supplements, like Tums or calcium carbonate, and most antacids bind chemically to levothyroxine in the stomach.
They basically trap the drug.
Exactly. They form these complexes, and the levothyroxine just doesn't get absorbed. It passes right through. So to prevent this, patients must take these interacting substances at least 4 hours apart from their levothyroxine dose.
4 hours. That requires some planning.
It really does. If someone's taking calcium for bone health and iron for anemia, they need a strict schedule.
Yeah.
Maybe levothyroxine first thing, wait an hour for breakfast, then wait several more hours before taking their calcium or iron. It's vital teaching.
Absolutely crucial detail. Now, when someone first starts levothyroxine, what are the nursing considerations? Especially for, say, older patients or those with heart issues.
This is critical. Starting levothyroxine is like turning up the speed on an engine that's been idling very slowly. It increases metabolic demand, increases oxygen consumption, and significantly increases the heart's workload.
So you have to start slow.
You must start with the lowest possible dose, especially in older adults or anyone with known coronary artery disease, CAD. If you give too much T4 too quickly, you can actually trigger serious heart problems: angina, chest pain, atrial fibrillation, worsening heart failure, even a heart attack, and MI.
Wow. So it's a careful titration.
Very careful. We start low, go slow, and monitor them very closely. We're watching for any signs of hyperthyroidism, a racing heart, palpitations, feeling hot, tremors, anxiety. If those appear, it means the dose is too high and it needs to be backed off immediately. We're constantly checking for that balance.
Okay, let's talk about the worst case scenario for hypothyroidism. Myxedema coma. This is that severe, life-threatening complication, high mortality rate, right? What usually pushes someone into this state?
It's often triggered by some kind of major stressor on a body that's already severely hypothyroid and can't cope. Common triggers are things like a bad infection, maybe surgery, exposure to cold, or trauma.
And medications.
Yes, critically, the use of certain drugs like narcotics, sedatives, or tranquilizers can precipitate it. Because the metabolism is so slow, these patients can't clear these drugs effectively, leading to profound CNS depression, which tips them over the edge.
So what does it look like when someone is sliding into myxedema coma? What are the key signs?
It's a picture of multi-system collapse, really.
Yeah.
The most striking thing is a significantly decreased level of consciousness, potentially progressing to actual coma.
And breathing.
Respiratory failure is a huge component. Remember that hypoventilation gets much worse, leading to high CO2 levels, respiratory acidosis. This is often what requires intubation. Hemodynamically, they become severely hypotensive, low blood pressure, and profoundly bradycardic, very slow heart rate.
What about temperature and labs?
Core body temperature plummets, profound hypothermia, sometimes dangerously low, like below 90 degrees Fahrenheit.
Lovely.
Lab-wise, you typically see hyponatremia, low sodium,
Mhm.
hypoglycemia, low blood sugar. Every system is failing.
Okay, this is clearly an emergency. What's the immediate action plan? How do nurses intervene?
The priorities are immediate stabilization and trying to reverse the underlying cause. It's a sequence.
Number one.
Airway and ventilation. Always. You have to secure a patent airway immediately. These patients often need mechanical ventilation to support breathing, manage that respiratory acidosis, and ensure adequate gas exchange.
Okay, airway secured, then what?
Hormone replacement. They need thyroid hormone urgently, but oral T4 won't work because their gut motility is basically shut down. So T4, and sometimes T3 as well, must be given intravenously, IV.
Makes sense. Bypass the gut. What else?
Metabolic support. Give IV glucose to treat the hypoglycemia. Often, IV corticosteroids are given too, because the intense stress of the coma can sometimes trigger adrenal insufficiency concurrently.
And managing the low temperature and blood pressure.
Right, monitor blood pressure and core temperature hourly. For the hypothermia, we need to warm them, but slowly. We use passive warming things like warm blankets. Aggressive rewarming like electric heating blankets is dangerous because it can cause vasodilation and make their blood pressure drop even further.
Okay. And ongoing monitoring.
Constant vigilant monitoring. The sources specifically highlight a safety alert. Assess the patient's level of consciousness, respiratory status, and overall condition at least every 8 hours, and report any change, even subtle ones, immediately. These patients absolutely need to be in an ICU setting.
A really complex and dangerous situation. Okay, that covers the slowdown crisis. Now, let's completely switch gears and look at the opposite problem. The body running way too fast. All right, hyperthyroidism, this is the flip side. Excessive thyroid hormone secretion. It cranks up the body's metabolism, hypermetabolism, and really stimulates the sympathetic nervous system, right? That fight or flight system.
Exactly. It's like the body is stuck in high gear, constantly revved up. Patients often describe feeling like they're running an internal marathon 21/7.
And just like with hypo, there's a primary autoimmune cause.
Yes, the most common cause is Graves' disease. And interestingly, it's also autoimmune. But the mechanism is the complete opposite of Hashimoto's.
Opposite how?
In Graves', the body makes autoantibodies. These are called thyroid-stimulating immunoglobulins, or TSIs. Instead of destroying the thyroid gland, these TSIs actually mimic TSH. They latch onto the TSH receptors on the thyroid cells.
And basically trick the gland into thinking the pituitary is telling it to work over time.
Precisely. They constantly stimulate the gland, forcing it to churn out excessive amounts of T3 and T4, completely overriding the body's normal feedback controls.
So Hashimoto's antibodies destroy, Graves' antibodies stimulate. That's a key difference.
It's a crucial difference in pathophysiology, absolutely.
Are there other major causes besides Graves?
Yes, another important one is toxic multinodular goiter, or TMNG. In this case, you have these lumps or nodules within the thyroid gland that just start producing hormones on their own, independent of any TSH stimulation. They become autonomous.
And the difference clinically, we talked about the eyes.
Right. The key differentiator is that TMNG does not cause the exophthalmos, the bulging eyes, that we see specifically in Graves' disease. That eye symptom really points towards Graves'.
Okay, let's look at the signs and symptoms through this lens of hypermetabolism. If the engine's running too hot, what does that look like?
Well, the increased basal metabolic rate leads directly to profound heat intolerance. These patients feel hot all the time, they sweat excessively, that's diaphoresis, and they often wear less clothing than others around them, even in cool weather.
What about their skin and hair? Opposite of hypo.
Exactly the opposite. Instead of dry and coarse, their skin is typically smooth, warm, and moist due to the constant sweating. Their hair might become very fine, soft, and silky.
Now, the cardiovascular system, this seems like a high-priority area again with that sympathetic overdrive.
It absolutely is. The heart takes a real beating. You see significant tachycardia, with resting heart rates often well over 100 beats per minute. Patients often complain of forceful palpitations, like their heart is pounding or skipping beats.
Blood pressure, too.
Usually, the systolic blood pressure is elevated. And there's a very high risk for developing dangerous heart rhythms, particularly atrial fibrillation, AFib, which significantly increases their stroke risk. Breathing is often rapid and shallow because the body's oxygen demand is so high.
How does this tie into nutrition? They're burning so much energy.
Right. They typically have a dramatically increased appetite. They might be eating constantly, yet they still often experience significant weight loss. Their body is just burning through calories incredibly fast. They also tend to have increased frequency of bowel movements, sometimes even diarrhea.
So eating more but losing weight, that's a big red flag.
A very big red flag for hyperthyroidism.
What about their mental state, neurologically and psychologically?
Think wired. They're often restless, hyperactive, and anxious. They can experience really wide, volatile mood swings. Concentration is difficult. They have a decreased attention span. Insomnia is very common. They just can't shut down.
Any physical neurological signs?
Yes, fine tremors, especially in the hands, are common. You might see it if they just hold their hands out. And their deep tendon reflexes are hyperactive or brisk. They just seem jumpy and irritable.
Okay, we have to talk more about the eyes and Graves' disease. Exophthalmos, what are the nursing concerns there? It's more than just cosmetic, right?
Oh, much more. That bulging is caused by the autoimmune inflammation and swelling behind the eye. A major complication is something called eyelid lag, where the eyelids don't close completely, especially when blinking or sleeping.
And that leads to?
That constant exposure dries out the cornea terribly. Patients experience severe eye dryness, discomfort, grittiness, excessive tearing as the eye tries to compensate, and significant photophobia sensitivity to light. The biggest risk is developing corneal ulcers, abrasions, or infections, which can potentially threaten their vision if not managed.
So nursing care is focused on protecting the eyes.
Entirely. It's about lubrication and protection. We teach them to use artificial tears or lubricating eye ointments frequently. Wearing dark glasses helps with the photophobia. If the lid lag is bad, they might need to gently tape their eyelids shut at night to protect the cornea during sleep. Elevating the head of the bed can also sometimes help reduce periorbital fluid.
Okay. And one really critical safety point regarding assessment, something we should not do.
Yes, absolutely crucial. Never vigorously palpate the thyroid gland or goiter of a patient who you suspect has hyperthyroidism.
Why not?
Because physically manipulating or squeezing an already overactive gland can potentially trigger a sudden, massive release of stored thyroid hormones into the bloodstream. And that surge can push them into a life-threatening thyroid storm. Gentle inspection is okay, but no deep palpation until they're stabilized.
All right, so we suspect hyperthyroidism based on those symptoms. How do we confirm it with labs? It's the reverse pattern of hypoparas.
Exactly the reverse. Because the thyroid is pumping out so much T3 and T4, the pituitary gland senses this excess and tries to shut down production via negative feedback. So it stops releasing TSH.
Meaning the lab results show.
You'll see low, often undetectable TSH levels and high levels of T3 and T4. That combination, low TSH, high T3, T4, confirms hyperthyroidism. And testing for those specific TREB antibodies, the thyroid-stimulating immunoglobulins we mentioned, helps confirm if it's specifically Graves' disease.
Okay, diagnosis confirmed. Let's talk treatment. The first line often involves antithyroid drugs, the thionamides. Can you compare the two main ones? Methimazole and propylthiouracil, PTU.
Sure, both methimazole and PTU work the same basic way. They get into the thyroid gland and block the enzymes needed to actually synthesize new thyroid hormones. They stop the factory from making more product.
Is one preferred over the other?
Generally, yes. Methimazole is usually the first choice. It tends to work a bit faster. It can often be dosed just once a day because it lasts longer in the body. And importantly, it generally has a lower risk of causing severe liver damage compared to PTU.
But PTU still has its uses.
It does. PTU is typically reserved for a couple of specific situations. One is if a patient has an allergic reaction or can't tolerate methimazole. The other, and this is really key for teaching, is during the first trimester of pregnancy.
Why PTU in early pregnancy?
Because methimazole has been linked to a higher risk of certain birth defects, particularly if used early on. So the standard practice is often to use PTU for the first trimester and then potentially switch back to methimazole later in the pregnancy if needed. However,
But there's a catch with PTU.
there is. PTU itself carries a known, though rare, risk of causing severe liver toxicity, including acute liver failure. It's a black box warning. So patients on PTU need regular liver function monitoring, and they must be taught the signs of liver problems like jaundice, dark urine, abdominal pain, and to report them immediately.
That's vital information, especially for women of childbearing age. What else do patients starting either of these drugs need to know?
Well, besides the pregnancy risks with methimazole and the liver risks with PTU, they need to understand the goal is to bring their thyroid levels down. hopefully towards euthyroid. But sometimes the dose can overshoot.
Meaning they become hypothyroid.
Exactly. So patients must be taught the signs and symptoms of hypothyroidism: feeling cold, gaining weight, fatigue, slow heart rate. If those appear, it likely means their dose is too high and needs to be adjusted downwards by their provider. Adherence is also key. These drugs take time to work.
Okay, moving on. What about iodine preparations, like SSKI, saturated solution of potassium iodide? How do they fit in?
Iodine solutions like SSKI are used differently. They're usually for short-term situations. High doses of iodine actually have a paradoxical effect. They temporarily inhibit the release of stored thyroid hormones and also interfere with new hormone synthesis.
And they affect the gland itself.
Yes, crucially, they make the thyroid gland smaller and much less vascular, less blood flow. This is incredibly useful right before thyroid surgery. Giving SSKI for about 10–14 days beforehand significantly reduces bleeding risk during the operation.
How is it given? Any special nursing points?
Yes, very specific instructions. It's given orally, but it needs to be diluted in something like water, juice, or milk because it tastes awful and can irritate the stomach. And patients absolutely must use a straw to drink it.
Why the straw?
To prevent it from staining their teeth. It's also important to give it about 1 hour after the daily dose of their main antithyroid drug, methimazole or PTU.
Good details. What about beta blockers like propranolol?
Beta blockers are purely for symptom control. They do absolutely nothing to fix the underlying thyroid problem. They don't stop hormone production.
So why use them?
Because they are fantastic at managing the symptoms of that sympathetic overdrive. They slow down the rapid heart rate, reduce palpitations, decrease tremors, and lessen anxiety and sweating. They provide significant relief relatively quickly while waiting for the antithyroid drugs, which can take weeks to really kick in. Propranolol is often a lifesaver for patient comfort and safety early on.
Okay, that covers the main drug classes.
Yeah.
What about the other major non-surgical option? Radioactive, iodine, RAI therapy, using I-131.
RAI therapy is a very common and effective treatment, especially for Graves' disease or toxic nodules. The patient swallows a capsule or liquid containing radioactive iodine, I-131.
And the thyroid absorbs it.
Exactly. The overactive thyroid cells are hungry for iodine, so they preferentially soak up the RAI. The radiation is then concentrated right within the thyroid gland, where it gradually destroys the overactive thyroid tissue over several weeks to months.
What's the usual outcome after RAI?
The destruction of the thyroid tissue almost always leads to the patient becoming hypothyroid eventually. This is actually the intended outcome.
So they trade hyperthyroidism for hypothyroidism.
Pretty much. And the resulting hypothyroidism is then managed long-term with daily levothyroxine, which is generally considered easier and safer to manage than uncontrolled hyperthyroidism.
Okay, since this involves radioactivity, even though it's targeted, there must be important safety precautions, right, for the patient and their family.
Absolutely critical. This is an unsealed radioactive source, meaning the patient themselves becomes radioactive for a period and excretes the isotope, mostly through urine, but also saliva and sweat. So strict precautions are needed, usually for several days, up to a week or more, depending on the dose.
What are the main rules?
Number 1 is limiting close contact, especially with vulnerable people. The patient should maintain a distance of at least 6 feet from others, particularly pregnant women, infants, and young children, for the prescribed time. They shouldn't sleep in the same bed with another adult. Brief contact is usually okay, but prolonged closeness isn't.
Okay, distance. What else?
Bathroom hygiene is huge. Since most of the RAI leaves through urine, they need to flush the toilet 2 or 3 times after each use. Men should sit down to urinate to avoid splashing. Good hand washing is essential. If possible, using a separate toilet is ideal, but if not, careful cleaning is needed.
And personal items.
Avoid sharing things that could transfer saliva or sweat. So don't share towels, toothbrushes, toothpaste tubes, drinking glasses, or eating utensils. Wash their laundry, towels, and bedding separately from the rest of the household's items for that initial period.
Anything else they need to know, like about travel?
Yes, good point. They should be aware that they might trigger radiation detectors at airports, border crossings, or even some hospitals for potentially several weeks after treatment. They should carry documentation from their doctor explaining they received RAI therapy.
Now, just like myxedema coma is the crisis for hypo, there's an equivalent for hyperthyroidism. Thyroid storm, also called thyrotoxic crisis. This sounds incredibly serious.
It is. It's an absolute medical emergency. It's a sudden, extreme worsening of hyperthyroid symptoms, and it carries a very high mortality rate if not treated rapidly and aggressively.
What triggers it? Similar stressors.
Yes, often similar stressors to mixed edema coma, but causing the opposite effect. Common triggers include infection, trauma, surgery, especially thyroid surgery if the patient wasn't properly prepared, diabetic ketoacidosis, DKA, stopping antithyroid meds abruptly, or
That vigorous palpation of the goiter we warned against.
exactly. That can definitely trigger it. Anything that puts severe stress on an already hyperthyroid body or causes a sudden surge of hormones.
So, how does thyroid storm present? What are the key signs that scream crisis?
Think hyperthyroidism magnified exponentially. The absolute hallmark is hyperthermia, a very high fever, often 105, 106 degrees F, 40.5, 41.1 degrees C, or even higher. Importantly, even an increase of just 1 degree Fahrenheit or about zero point 0.6 degrees C in a patient known to be hyperthyroid should be considered potentially ominous and needs immediate investigation.
Wow, just 1 degree. What else?
Extreme tachycardia, heart rates often soaring above 130 beats per minute, sometimes much higher, often with dangerous arrhythmias like AFib or ventricular tachycardia. Severe hypertension initially, though they can crash later. Neurologically, they become extremely agitated, restless, anxious, often confused, potentially psychotic, and can progress rapidly to delirium, seizures, stupor, and coma.
Any GI symptoms?
Yes, often significant abdominal pain, nausea, vomiting, and sometimes jaundice if the liver is affected by the stress.
This sounds terrifying. What's the emergency care plan? How do we intervene immediately?
It requires a rapid, multi-pronged attack. The priorities are cooling them down, blocking hormone effects, and supporting vital functions.
Okay, step one.
Airway and ventilation again. Always priority one. Maintain a patent airway. Provide supplemental oxygen. They may need intubation and mechanical ventilation if their respiratory status deteriorates or level of consciousness drops significantly, ensuring adequate gas exchange.
Okay, airway managed, then.
Block the hormone effects. This involves several drugs given urgently. First, antithyroid medications like methimazole or PTU are given, often in large doses, to stop the thyroid from making new hormones. PTU might be preferred initially because it also blocks the conversion of T4 to the more potent T3 in the rest of the body, giving a slightly faster effect.
What else for blocking?
Iodine solutions, like SSKI or Lugol solution, are usually given about an hour after the first dose of the antithyroid drug. This helps block the release of hormones already stored in the gland. And crucially, beta blockers, usually propranolol given high IV, are essential to control that extreme heart rate, hypertension, and arrhythmias.
So stop production, stop release, and block the effects on the heart. Makes sense. What about the fever?
Cooling measures are vital. External cooling with cooling blankets, ice packs, especially the axilla and groin, and fans. Sometimes antipyretics like acetaminophen are given, though they may not be very effective against this kind of metabolic fever. Avoid aspirin, as it can actually increase thyroid hormone levels.
And fluid support.
Absolutely. They're often severely dehydrated from the fever and sweating. 4V fluids, usually cooled normal saline or dextrose solutions, are given to correct dehydration and help with cooling. Electrolytes need close monitoring and replacement.
Anything else?
Corticosteroids, like hydrocortisone or dexamethasone, are almost always given IV. This helps the body cope with the extreme stress, can reduce the T4 to T3 conversion, and treats any potential relative adrenal insufficiency. And of course, you treat the underlying trigger if you can identify it, like starting antibiotics for an infection. Vital signs need to be monitored constantly, like every 15-30 minutes initially.
It really is like slamming on the brakes physiologically while supporting everything else. A very intense situation. So we've covered non-surgical treatments, but sometimes surgery, a thyroidectomy, removal of the thyroid is the best option. When is surgery typically considered?
Surgery is usually reserved for specific situations. For example, if someone has a very large goiter that's causing compression symptoms, difficulty swallowing or breathing, or if they have confirmed or suspected thyroid cancer. Sometimes it's done if drug therapy fails or isn't tolerated, or if the patient, particularly with Graves, prefers surgery over RAI. It can be a total removal or a subtotal removal, leaving a small part of the gland.
You mentioned preparation is key. Getting the patient to a euthyroid state before surgery is vital, right?
Absolutely paramount. You do not want to operate on someone who is actively hyperthyroid. The risk of triggering a thyroid storm during surgery is just too high.
So how do they get them euthyroid?
Typically, they'll be treated with antithyroid drugs like methimazole for several weeks or months beforehand to get their hormone levels down into the normal or near normal range.
And then the iodine prep we talked about.
Yes. Once they're pretty much euthyroid, they'll usually receive an iodine preparation like SSKI or Lugol solution for about 10 to 14 days right before the scheduled surgery date.
Remind us why the iodine is used just before surgery.
That short course of high-dose iodine makes the thyroid gland itself firmer, smaller, and significantly less vascular. It reduces blood flow to the gland. This makes the surgery technically easier and, more importantly, dramatically reduces the risk of excessive bleeding during and immediately after the operation. It's a crucial safety step.
Okay, patient is prepped. Surgery is done. The first 24 hours post-op are critical. What are the biggest nursing priorities? Let's start with bleeding. Hemorrhage.
Hemorrhage is a major concern, especially in those first 12-24 hours. The neck is a very vascular area. Nurses need to monitor vital signs frequently, often every 15 minutes initially, then progressing to every 30 minutes, then hourly, watching closely for tachycardia or hypotension, which could indicate bleeding.
And checking the dressing.
Checking the dressing is important, yes. Look for any visible saturation. But critically, you can't just look at the front dressing. Because of gravity, blood can easily pool behind the patient's neck or trickle down onto their upper back and shoulders.
So you have to physically check back there.
You absolutely have to gently support their head and neck and inspect all around the incision site and behind the neck for any swelling, discoloration, or pooling blood. Also, assess for feelings of fullness or pressure in the neck, which the patient might report.
Got it. Priority number 2, potentially even more immediately life-threatening, respiratory distress. How does that relate to gas exchange?
Respiratory distress after thyroidectomy is a huge emergency. It can happen for a few reasons. Bleeding into the tissues can cause swelling, hematoma, that directly compresses the trachea, blocking airflow. There could also be edema around the airway, or, less commonly, damage to the recurrent laryngeal nerve which controls the vocal cords, potentially causing them to spasm or close.
What's the telltale sign of airway obstruction?
The cardinal sign is stridor. That's that harsh, high-pitched whistling or crowing sound heard usually on inspiration. If you hear stridor, it means the airway is critically narrowed and you need to act immediately.
What's the immediate action?
Call for help. Rapid response team, surgeon, anesthesia. Ensure that the emergency tracheostomy tray and functioning suction equipment are right there at the bedside. They must be in the room for every post-thyroidectomy patient.
What else can be done? Positioning.
Keep the patient in a semi-Fowler's position, head of bed elevated 30-45 degrees, to help reduce swelling and promote drainage. Encourage deep breathing exercises. Teach them to support their neck with their hands when coughing or moving to avoid strain on the incision. But if stridor develops, prepare for potential emergency intubation or tracheostomy.
Okay, third major complication, related to those tiny glands nearby. Hypocalcemia and tetany. This involves the parathyroids, right?
Exactly. There are usually 4 tiny parathyroid glands embedded in or very close to the thyroid. During a thyroidectomy, they could be accidentally removed, damaged, or their blood supply can be compromised.
And the parathyroids control calcium.
Yes, they produce parathyroid hormone, PTH, which keeps blood calcium levels up. If the parathyroids are gone or not working, PTH levels drop, and consequently serum calcium levels fall. Hypocalcemia.
And low calcium causes nerve problems.
Right. Low calcium makes nerve and muscle fibers hyperexcitable. They fire much more easily. This leads to the symptoms of tetany.
What are the early signs nurses need to watch for?
The earliest signs are often sensory tingling and numbness, often described as pins and needles, paresthesias, typically around the mouth, lips, or in the fingertips and toes.
And if it progresses?
It can progress to muscle twitching, cramps, and eventually severe muscle spasms, particularly of the hands and feet, carpopedal spasm, and even spasm of the larynx, laryngospasm, which can also cause airway obstruction. Seizures can occur in severe cases.
How do we check for this neuromuscular irritability specifically?
There are 2 classic bedside tests. 1, Schwostek's sign. You gently tap the facial nerve just in front of the ear. A positive sign is a twitching or spasm of the facial muscles on that same side, like the corner of the mouth or eyelid. 2, Trousseau's sign. You inflate a blood pressure cuff on the patient's upper arm to a pressure slightly above their systolic BP and keep it inflated for about 2-3 minutes. A positive sign is the development of a carpal spasm. The wrist flexes, the fingers extend, and the thumb adducts, kind of like making a claw hand.
If either of those signs is positive or the patient reports tingling, what needs to be ready?
You must have IV calcium gluconate readily available at the bedside. This is the emergency treatment for acute symptomatic hypocalcemia. It needs to be administered slowly, by IV if needed, to prevent tetany from progressing to laryngospasm or seizures. Serum calcium levels will also be monitored closely post-op.
Okay. One last potential issue, voice changes.
Yes. The recurrent laryngeal nerves run very close to the thyroid. They control the vocal cords. Some temporary hoarseness or a weak voice is actually fairly common right after surgery due to swelling or irritation near the nerves.
But it should get better.
Usually, yes. But the nurse needs to assess the patient's voice quality regularly, maybe every 1–2 hours initially. Ask them to speak. Note the tone, clarity, and volume. If the hoarseness gets worse, or if it's accompanied by any respiratory difficulty or stridor, it could indicate nerve damage or significant swelling and needs to be reported immediately.
Okay, we've thoroughly covered the thyroid as the body's thermostat. Now let's pivot to its neighbors, the parathyroid glands. Tiny glands, big job regulating calcium, right?
Absolutely. Usually 4 of them, sometimes more, sometimes fewer, typically located on the back surface of the thyroid. Their sole purpose is to secrete parathyroid hormone, or PTH,
And PTH's main job is?
to keep blood calcium levels within a very tight normal range. When serum calcium starts to drop, the parathyroids release PTH.
How does PTH raise calcium?
It works in 3 main ways. 1, it pulls calcium and phosphate out of the bones. This is called bone resorption. 2, it tells the kidneys to reabsorb more calcium back into the blood instead of letting it go out in the urine. 3, it also tells the kidneys to excrete more phosphate. And indirectly, it helps activate vitamin D, which increases calcium absorption from the gut. The net effect is increased serum calcium.
So if PTH levels drop, calcium levels drop. That leads us to hypoparathyroidism. We just discussed this as a risk after thyroid surgery.
Exactly. Hypoparathyroidism means insufficient PTH secretion. The most common cause by far is accidental damage or removal during neck surgery, especially thyroidectomy. Rarely it can be autoimmune or congenital.
And the result is that electrolyte imbalance.
Low PTH leads directly to hypocalcemia, low serum calcium.
Yeah.
And because PTH normally helps excrete phosphate, you also get hyperphosphatemia, high serum phosphate.
And the symptoms are all driven by that low calcium, causing nerves to be overexcitable.
Precisely. It's the same picture we see with post-op hypocalcemia. The symptoms are directly related to neuromuscular irritability from the low calcium levels. So tingling, numbness, paresthesias, muscle twitching, cramps, spasms, and in severe cases, tetany, those painful, sustained muscle contractions, laryngospasm, and seizures.
And we'd expect positive Schwostek's and Trousseau's signs again.
Definitely. Those signs just indicate significant hypocalcemia, whatever the cause.
How is hypoparathyroidism treated? Acute versus long-term?
If it's an acute, severe drop in calcium causing tetany, the emergency treatment is IV calcium gluconate, given slowly to rapidly boost serum calcium and stop the spasms.
And for chronic management?
Since the parathyroids aren't working, treatment is lifelong. It involves oral calcium supplements, usually calcium carbonate taken multiple times a day with meals for better absorption. And critically, they also need vitamin D supplementation, often in an active form like calcitriol.
Why the vitamin D?
Because your body absolutely needs vitamin D to be able to absorb calcium from your food and supplements in the gut. Without enough vitamin D, the calcium supplements won't do much good.
What are the key teaching points for someone living with chronic hypoparathyroidism?
They need to understand it's lifelong therapy and adherence is crucial. Diet should be high in calcium. Think of dairy products, leafy greens, fortified foods, but actually low in phosphorus, avoiding things like processed meats, sodas. They should wear a medical alert bracelet, because if they develop acute symptoms, it can look like a seizure disorder or other neurological issues, and healthcare providers need to know about the underlying calcium problem.
Okay, that covers low PTH. Now let's look at the opposite. Hyperparathyroidism, too much PTH leading to too much calcium.
Right. Hyperparathyroidism is much more common than hypo. It's usually caused by a benign tumor, an adenoma on one of the parathyroid glands, causing it to just pump out way too much PTH, regardless of the body's calcium levels. Less often, all 4 glands might be enlarged, hyperplasia.
So excess PTH leads to the opposite electrolyte imbalance.
Correct. Too much PTH leads to hypercalcemia, high serum calcium, and hypophosphatemia, low serum phosphate, because PTH makes the kidneys waste phosphate.
And the main mechanism for that high calcium is PTH pulling it from the bones.
Yes, that's the primary driver. Chronic high PTH constantly stimulates osteoclasts, the cells that break down bone, leading to excessive bone resorption. Calcium pours out of the skeleton and into the bloodstream.
This constant leaching of calcium causes a pretty unique set of symptoms, often summarized by that mnemonic.
Exactly. The classic, slightly morbid mnemonic is bones, stones, abdominal moans, and psychiatric overtones. It helps remember the key areas affected by chronic hypercalcemia.
Let's break that down. Bones.
Bones. The chronic bone resorption leads to loss of bone density, making bones weak. This can result in osteoporosis, bone pain, pathological fractures, fractures that happen with little or no trauma, and sometimes bone cysts, stones. High levels of calcium circulating in the blood and being filtered by the kidneys significantly increases the risk of forming kidney stones, renal calculi. These can be painful and cause kidney damage.
Abdominal moans.
Abdominal moans. High calcium levels can affect the smooth muscle of the gastrointestinal tract, leading to vague symptoms like anorexia, loss of appetite, nausea, vomiting, constipation, and general abdominal discomfort. Peptic ulcer disease is also more common.
And psychiatric overtones.
Psychiatric overtones. Hypercalcemia tends to depress the central nervous system. This can manifest as fatigue, lethargy, drowsiness, confusion, memory problems, depression, and in severe cases, usually when calcium levels get very high, like above 12 milli-GDL or so, even psychosis or coma.
Wow, it really affects multiple systems. How is it diagnosed?
Diagnosis relies on lab tests showing persistently elevated serum calcium levels along with elevated PTH levels. Normally, high calcium should suppress PTH, so finding both high tells you the parathyroids are inappropriately overactive. Sometimes imaging tests, like a sestamivi scan or ultrasound, are used to try and locate the overactive glands, especially before surgery. Bone density scans, DXA, are often done to assess the skeletal impact.
What about treatment? Is surgery the main option?
For symptomatic patients, parathyroidectomy, surgical removal of the adenoma or the overactive glands, is the primary and usually curative treatment.
What if someone is asymptomatic or can't have surgery? Is there non-surgical management?
Yes. For patients with mild hypercalcemia and no symptoms, or for those who aren't surgical candidates, medical management is used. The focus is on preventing complications. This often involves hydration, encouraging lots of fluids to help prevent kidney stones, and sometimes medication.
What kinds of medications are used?
There are two main classes used for non-surgical management. 1. Calcimimetics. The main drug here is cinacalcet. Pretty clever, it basically mimics calcium. It binds to the calcium-sensing receptors on the parathyroid glands and tricks them into thinking there's already enough calcium in the blood. This makes the glands release less PTH.
So it lowers PTH and therefore lowers calcium.
Exactly. It helps control the hypercalcemia. 2. Bisphosphonates. These are drugs like alendronate or zoledronic acid. They don't directly affect PTH, but they are crucial for protecting the bones. They work by inhibiting the osteoclasts, those bone-resorbing cells. This helps prevent further bone loss and reduces the risk of fractures. They're often given IV initially.
Okay, so since bone health is a major issue here, nursing interventions must focus heavily on safety, right? Preventing injury.
Absolutely. That's the #1 priority, especially for patients with significant bone loss. Fall prevention strategies are critical, and nurses and assistive personnel, AP, need to use extreme care when moving or repositioning these patients.
Like using lift sheets?
Yes. Always use lift sheets to move them in bed. Avoid pulling on their arms or legs. Gentle handling is key to prevent causing pathological fractures. Encouraging ambulation, if possible, helps maintain bone density, but safety first. And, as mentioned, pushing fluids, hydration is vital to try and prevent those painful kidney stones from forming by keeping the urine dilute. #OutRocho.
Wow, we've really covered a lot of ground today, from the thyroid's metabolic speed control to the parathyroid's grip on calcium. If you're trying to synthesize all this, what's the core takeaway? The quickest way to differentiate hypo from hyper?
I think the simplest way is just, hypo is slow. Think slow, cold, tired, weak, weight gain, slow heart, slow breathing. Hyper is fast. Think fast, hot, anxious, wired, weight loss, fast heart, maybe tremors. And remember, the autoimmune causes are opposite. Hashimoto's destroys the thyroid. Graves' disease overstimulates it.
And we hit those critical safety anchors. The emergencies, myxedema, coma, and thyroid storm, remembering hypo needs warming and careful speeding up, while hyper needs cooling and slamming the brakes.
Exactly. And the post-thyroidectomy risks. Hemorrhage, always check behind the neck. And hypocalcemia, tell the knee, know the signs, Schwastex and Trousseau's, and have that IV calcium gluconate ready.
Plus, the crucial medication teaching points. Levothyroxine timing and that 4-hour separation rule for minerals are non-negotiable.
Absolutely. And with the antithyroid drugs, watching for signs of the opposite state, hyperthyroidism, and being aware of those specific risks, like liver toxicity with PTU or birth defects with methimazole. Getting the management right minimizes risk from both the disease and its treatment.
It's really incredible how these small glands wield such enormous influence over our energy, our heart rate, our temperature, even the strength of our bones. That interconnectedness of the endocrine system is just fascinating.
It really is. And it leaves you with a final thought, doesn't it? We talked about getting back to euthyroid or normal calcium, that state of balance.
Hmm.
Failure to maintain it causes dramatic problems. So it makes you wonder,
What's that?
how much of our day-to-day feeling, our energy levels, our mood, maybe even sleep quality, might be influenced by much more subtle hormonal shifts. Fluctuations that maybe don't quite meet the criteria for a diagnosis, but are still nudging our body slightly out of that perfect sync. What other hormones might be quietly running the show behind the scenes?
Definitely something to think about as we all consider our own internal balance. Thank you for joining us on this deep dive.